Thanks, Will. And if Justin's still on, thanks for being with us this morning and taking the time to present and lead us through that discussion. I'll echo that. I worked with Justin when he was a fellow as well, and he's like just really masterful at having those discussions with his teams, and so intentional about just sitting down with like all his junior learners and talking through what their preferences are, if confronted with those situations. I'm gonna pivot a little bit, obviously, to talking about a very different topic, and that's adrenal insufficiency. And my sort of main motivation for talking about this is I think that we don't get really like a lot of dedicated endocrine teaching in general. And I just came off of a endocrine consult elective where we saw a lot of adrenal insufficiency. And I think this can be sort of we don't think about it quite enough, either inpatient or outpatient. And when we do think about it inpatient, the settings that I've had to think about it have been really in the context of people like in the MICU who are really hypotensive on a couple pressors, and then we start steroid and the regulation of cortisol production just briefly, and give us sort of a baseline to thinking about how to think about how adrenal insufficiency or cortisol insufficiency may present in your primary care clinics, and then talk a little bit about the different options for testing and um, how to assess something that's going on primarily in the adrenal gland from a problem that's going on a little bit higher up in either the pituitary or the hypothalamus. Then we'll talk a little bit about switching course into adrenal crisis, how to think about that and identify that inpatient, and how to start an appropriate steroid regimen. And then most of these patients will be seeing endocrinologists, but they should have frequent touches with the healthcare system. And so at the end, I want to talk a little bit about patient education and management of adrenal insufficiency and the things that you can make sure that people receive counseling on outside of a specialist. So just to very quickly dive into a little bit about adrenal physiology. So you have these two different layers that the adrenal gland is made up of, the outer cortex layer and then the inner medulla. The medulla is what's responsible for synthesis of things like epinephrine and norepinephrine. We won't really go into those topics so much today, but those are regulated by your sympathetic nervous system. We'll talk a lot more about the cortex, which is where your three major hormones that the adrenal gland synthesizes are made in the cortex. So your mineralocorticoids or aldosterone, your cortisol, which is a glucocorticoid, and then your sex hormones or androgens, which is DHEA. And so I'm sure a lot of you in medical school learned about the cortex as the salt, sugar, and sex hormones, and that's these three: aldosterone, cortisol, and DHEA. The cortisol regulation is a little bit different from the aldosterone regulation. So we'll talk a little bit about which of these hormones is lost in different conditions as well. But cortisol is sort of the main one that we think about in terms of adrenal insufficiency. It's produced by your adrenal glands. It's regulated by the hypothalamus, which produces this molecule called CRH, or corticotropin releasing hormone. And that's released in this pulsatile circadian way in response to stress. And that causes the anterior pituitary to make ACTH. And that's the signal to your adrenal glands to make cortisol. And in people who live sort of this typical schedule where they go to sleep at night, wake up early in the morning, 3 hours after sleeping, and then a peak 2 to 3 hours after waking up. Night shift workers have a little bit of a different cortisol profile with a flattened profile throughout the day. They don't get these as obvious surges upon awakening. And when they wake up in the afternoon, evening, they don't get it's not completely just switched to their nighttime schedule. The surge that they get when they wake up is lower than what you would normally expect for someone who wakes up during the day. And then their cortisol when they go to sleep is also higher than what would typically be expected for someone who has sort of a normal schedule where they go to sleep at night. Um, so I think one of the hard parts for thinking about this in clinic is chronic adrenal insufficiency is not that common, and the way that it presents can be really vague. So presents with this kind of vague constellation of symptoms like fatigue, GI symptoms, including nausea, vomiting, abdominal pain. You can have unintentional weight loss. You can have depression, anxiety, oftentimes, and psychosis, and then generalized muscle and abdominal pain as well. So fatigue is probably one of the most common symptoms for people with chronic adrenal insufficiency. And in a few studies, they found that 20% of patients had symptoms of fatigue for almost 5 years before they were diagnosed with AI. So it's a diagnosis that can be really delayed if providers aren't thinking about it. Amenorrhea or abnormal menstrual periods can also develop in up to 25% of women with adrenal insufficiency. And there's a couple different mechanisms that are at play here. One is weight loss by itself can cause dysregulated menstrual periods or amenorrhea, but also people with primary adrenal insufficiency can develop a concurrent autoimmune mediated primary ovarian insufficiency. So that's if people have problems with their adrenal glands in and of itself due to an autoimmune etiology, that can predispose people to having autoimmune related ovarian diseases. And then at the level of the pituitary, if there's something that's going on where ACTH is abnormal, then the pituitary can, which also produces, all these other hormones, they can also have effects on things like LH and FSH and prolactin production. And um, one of the one of the features that can be helpful if you're doing, pretty broad workup for these patients with fatigue or unintentional weight loss, probably going to get a BMP at some point. And 70 to 80% of patients with both primary and central adrenal insufficiency have hyponatremia. It's a little bit of a different mechanism between primary and secondary, depending on if they've also lost their aldosterone. But if, just cortisol insufficiency in and of itself can cause hyponatremia because cortisol is involved in vasopressin metabolism, and if you have and vasopressin recycling out of the kidney. And so if you have less cortisol, then you have increased vasopressin and you have increased persistence of those aquaporins in the nephron, which leads to increased water retention. And I'll mention that one other thing I'll mention for this is that, oftentimes with this constellation of symptoms, especially the unintentional weight loss, anorexia, fatigue, it's a delayed diagnosis, but it's a delayed diagnosis, particularly in young women who often get misdiagnosed with eating disorders when they have adrenal insufficiency. And so this is a really important thing to rule out, and especially in those patients. So the diagnosis of adrenal insufficiency can, I think, on the surface seem a little bit complicated just because there's a few different options. There's sort of a multi-step diagnosis, but I think the biggest thing is to keep it in mind. And if you keep it in mind, then the algorithms for doing the lab testing for this are actually fairly, you can find them on UpToDate. They're fairly straightforward. There's a couple of different options just for the initial testing for adrenal insufficiency. The first of which is to get an AM cortisol. And an AM cortisol, what you're looking for in adrenal insufficiency is just, do they have low production of cortisol? So you're going to obtain an AM cortisol because in most people, this is the time when cortisol should be highest. And so it should be typically obtained about 3 hours after waking for someone who sleeps at night. And so that's typically between 6 to 9 a.m. That you'll get this test. And I think about this as extremes on this testing are helpful. So if you have a really, really low cortisol level, which is less than 3, then that's strongly suggestive of AI. But a cortisol level greater than 13 to 14, you can likely rule it out. And like with everything, this sort of depends on your pretest probability of someone having adrenal insufficiency in the first place, which, as I mentioned before, it can be a little bit tough because this isn't, it's not that common. The prevalence is not that high and the symptoms are vague. So it's not often that you're going to have a really high pretest probability anyway for this. Um, but the AM cortisol can be a good first sort of pass in thinking about, is this patient's cortisol production clearly out of sync? Um, and so less than 3, strongly suggestive of AI, greater than 13 or 14, you can likely roll it out. It's this sort of intermediate region where we move on to more uh, other testing, including like a cosentropin stim test. But I'll mention that even if someone has a AM cortisol that's really low and that you want to make a diagnosis of AI, confirmatory testing for this really requires a stim test. And so that's this next slide. So you've done your AM cortisol, it's either low or it's indeterminate. And this is where you have people come back and you measure their serum cortisol again, and then you give them 250 micrograms of ACTH or cosentropin, and then you have them wait in the lab for 30 minutes and 60 minutes. And often outpatient, this can be hard to coordinate. It can be hard to coordinate when they get their medications and just have like the lab and the nursing staff to support that. But what you're looking for here is that you give a super physiologic dose of ACTH, and you're seeing how the adrenal glands, if they can maximally respond to that. And so even though you're getting this baseline 30-minute and 60-minute injection or 60-minute readings, the interpretation of your cortisol is going to be based on the peak level, which is most often at 60 minutes. And you're not looking at the change as much. So you're not looking at the incremental or the percent increase in change. And that's because people who have a high basal serum cortisol level, either due to sort of an acute stress or differences in circadian rhythm, they can have a high normal basal serum cortisol to start with, and so their delta is just not going to be helpful for you. Um, and so the way that you interpret this is, again, if their adrenal glands aren't producing cortisol, their absolute threshold, their max response of less than 14, you're likely diagnosing that person with AI. And if it's greater than 18, then it's generally excluded. And then this is also, again, where you have this intermediate region where you have a value between 14 to 18 that it's not clear what you do with that. And so you need to, at that point, most of the time you're done with cortisol testing for adrenal insufficiency, and you're looking for other hormones which might be affected. And the one that's affected in both primary adrenal insufficiency, but also in central adrenal insufficiency, is your androgen hormones or DHEAS. So that's when you would get that level. And if that's low, then you can feel pretty confident that they have adrenal insufficiency. So for diagnosis, you can start with an AM cortisol. If that's low or equivocal, move on to the cosentropin stim test. And then again, if that's low, that's likely AI. If it's high, you've likely excluded AI. But then if it's, again, in that intermediate zone, you're looking for additional hormone testing. And so
Chris, can I just
yeah,
pause you? There is a question in the chat. Um,
yeah, so Joanna, that's a good question. Why we check at 30 and 60 minutes. So if they reach greater than 18 at 30 minutes, you don't have to check at 60 minutes. Yeah, so it's not been shown to have either improved sensitivity or specificity between checking at 30 minutes and 60 minutes. What you're looking for is most people will maximally stim at 60 minutes, but my understanding is some people will at 30 minutes. And there's just it hasn't been shown that one is superior to the other. So once we've, made this diagnosis with our AM cortisol and our cosentropin stim test, the last piece of our sort of 3 lab evaluation is getting just a morning ACTH level. And that is to differentiate between, again, a primary adrenal pathology versus is there something going on higher up with either the hypothalamus or the pituitary, which we call central adrenal insufficiency. And so this again is measured in the early morning, 6 to 9 a.m. And this is a little bit more straightforward, where elevated ACTH is more consistent with primary AI. And if you think about what's going on at the adrenal level, if your adrenal glands aren't making cortisol, then that's not able to exert that negative feedback on the hypothalamus and the pituitary. And so you constantly are then receiving increasing signals for ACTH from your hypothalamus or from your pituitary. So you get an elevated ACTH. Whereas in central AI, the problem is really in the hypothalamus or the pituitary itself not sending that signal. So you get either a low ACTH or what's an inappropriately normal ACTH. And then a couple caveats to this testing is checking someone's albumin is important, and oftentimes, this comes up, especially inpatient when we're testing people for adrenal insufficiency or crisis. And the cortisol is it's a lipophilic molecule, and it's bound to CBG, or this molecule called corticosteroid binding globulin. And so your total cortisol levels can be falsely low in patients with either low protein albumin states or high CBG, which is seen most often in people taking oral estrogen for contraception or pregnancy. And so in these cases, sometimes a salivary cortisol can be helpful as the way to do testing, but this is, it's not always available. But the thinking is that it's more correlated with your serum-free cortisol, and so it's not related to these reasons that cause disturbances in your protein levels. So if you have high CBGs, the total cortisol that you measure can be artificially high, and you can miss a diagnosis of adrenal insufficiency. Whereas if your CBG is low in, cirrhosis, nephrotic syndrome, or sepsis, then your total cortisol can be artificially low, and you might miss this diagnosis. And then in regards to the ACTH stim test, the rationale that we use to test for both primary and secondary adrenal insufficiency using that stim test is to try and get the adrenal glands to make as much cortisol as they can. In primary AI, where the problem is at the adrenal gland, your adrenal glands just don't have that function. So even if you maximally stim them, they're not going to produce cortisol to the level that they should. And then in the interpretation for central adrenal insufficiency is a little bit more nuanced, and it depends on the timing. If you think that your patient has had chronic central adrenal insufficiency and chronic hypoproduction of ACTH, where their adrenal glands haven't been receiving that signal for so long, that over time leads to atrophy of the adrenal glands, and that's why you don't see a response when you do the stim test. But if you've lost sort of that ACTH signal just in the past 4 to 6 weeks, the adrenal glands may not have atrophied by that point, and if you stim them, they may be able to produce a level of cortisol that is not going to meet your definition of adrenal insufficiency. So that's the one caveat that I would try and keep in mind and try to suss out how long someone's symptoms are. And it's this subacute period where the stim test can be difficult to interpret. So going through a little bit of the different clinical manifestations and etiologies of primary AI. So it's relatively rare. Primary AI is also called Addison's disease, and it's the sort of differential for it is different depending on the setting that you're in. In high resource countries, in Nordic countries where autoimmune adrenalitis is a little bit more common, it's still relatively rare, between 15 to 20 cases per 100K individuals. And the most common etiologies in those settings are autoimmune adrenalitis, and then in children, genetic conditions that we don't really think about are the most common cause. And then in more resource-limited settings, TB is going to be your most common cause of this condition. So we mentioned a little bit earlier the sort of symptoms that are associated with adrenal insufficiency, that fatigue and the nausea, weight loss, your gastrointestinal symptoms, and then hyponatremia. Those are all because of loss of cortisol chronically. In primary AI, you also lose mineralocorticoid synthesis. Aldosterone is regulated by renin, the renin-angiotensin system, and that's not affected if you have central AI, where you just have loss of ACTH. But in primary AI, where the whole adrenal gland is down, you do lose aldosterone. So you get symptoms that would be related to loss of that ability to hold on to salt and water and to get rid of potassium. So often these patients, we'll ask them if they've been having a lot of salt cravings, if they've been eating a lot of potato chips, or even drinking like pickle juice sometimes. And on their labs, they can have hyperkalemia, and they can have a greater incidence of orthostatic hypotension because of that loss of aldosterone. Um, on your exam, this also manifests a little bit differently compared to central AI. And so in primary AI, you have increased ACTH, and ACTH is produced in conjunction with melanocyte stimulating hormone. And so if you have high ACTH, you also have high melanocyte stimulating hormone in that setting. And the areas that you can particularly see hyperpigmentation, you get diffuse hyperpigmentation, but the places you really see it are in the palmar creases, in the buccal mucosa, in the vermilion border of the lips. And those places are especially good to look for hyperpigmentation in darker skinned individuals. You can ask, family members if they've noticed hyperpigmentation or darkening of their family member's skin, or you can compare, family member skin to each other too, if it's difficult to really assess. And then primary AI, because it's oftentimes an autoimmune adrenalitis, it's often associated with other autoimmune endocrinopathies, including things like Hashimoto's, Graves, and type 1 diabetes. And then here are some other etiologies of primary AI. For this workup, you're often going to get a CT abdomen pelvis looking for basically most of these things. And the other workup that you or an endocrinologist will send is this anti-21 hydroxylase antibody, and that tests for autoimmune adrenalitis. And for infectious etiologies, again, it's primarily TB, and most of these patients with TB adrenal insufficiency are going to have obvious active TB elsewhere, whether that's pulmonary or other signs of systemic TB. And then in patients with HIV, other than TB, CMV is the most common cause, as well as histoplasmosis. And histoplasmosis is on the rise due to climate change and due to bat and poultry exposure. And then in terms of malignancy, you can have primary adrenal tumors. Oftentimes these are lymphomas, but more commonly you have metastases from solid organ tumors like lung, colon, breast cancer, or lymphoma and melanoma. And then there's also infiltrative causes like sarcoid, hemochromatosis, amyloid. And again, the main workup for primary AI after you've gotten your initial testing with your high ACTH is going to be a CT abdomen pelvis, and then again the anti-21 hydroxylase. And then in the other bucket, so we've again established a diagnosis of adrenal insufficiency. We've gotten a low AM cortisol, or we've gotten a low cosentropin stim test. And then now we've had a low normal ACTH. So central AI refers to either problems in the pituitary or in the hypothalamus. And compared to primary AI, you're not going to see that hyperpigmentation because you don't lose or you don't gain a lot of melanocyte stimulating hormone. But you're going to see low DHEAS, which is that androgen that's produced in the adrenal gland. And then mineralocorticoids, you're not going to see affected. So you won't see hyperkalemia. You may not see the same degree of orthostatic symptoms as well, but you will see hyponatremia again, just because of the cortisol pathophysiology that's related there. And so the workup for central AI, rather than a CT abdomen and pelvis, is going to be an MRI of your pituitary, and then evaluation for the other pituitary hormones of the anterior pituitary, which are going to be, FSH, LH, TSH, a prolactin, a growth hormone, and then insulin growth factor is the way that you assess that. And oftentimes the history taking for these patients can be really revealing. People with central AI etiologies, it's important to do a medication rec. And the most common cause of suppression of ACTH release from the pituitary is going to be steroids. So an equivalent of more than 5 milligrams of steroids for more than 2 weeks is enough to put people at risk for central AI or suppression of ACTH. And when you're gathering this history, oftentimes you just think about oral steroids or IV steroids, but intra-articular or topical or epidural injections, those can also combine and cause you to have cumulative suppression of the HPA axis. And then after that, the most common etiologies of central AI are going to be issues with your pituitary gland. So that's either masses like a pituitary adenoma, and those are at that time, that's going to be when you ask questions about those other pituitary hormones, but also asking about, compressive symptoms like headache, visual field deficits, seeing if people have, abnormal cranial nerve like 346 and abnormal extraocular movements due to compression of the adenoma on their optic chiasm. And then other things that could, go on in the brain, trauma, surgery, radiation, other masses. And then hypophysitis is one that is becoming more and more common, especially related to immune checkpoint inhibitor use, which causes this kind of medication-related irreversible hypophysitis where you lose a lot of your anterior pituitary hormones. And then something that we don't think about as much is Sheehan syndrome, which is also not that common, but Sheehan syndrome is when after pregnancy, if you have significant postpartum hemorrhage, then you have relative ischemia and infarct of your pituitary, and it can cause you to have adrenal insufficiency. And the last one is chronic opioid use, which we more commonly see, can also cause central AI because it suppresses your ACTH regulation. And this is I couldn't find really good data for what's considered, a dose or like a period of time on chronic opioids to put people at risk for this. But I think it's safe to say that prolonged use and then higher doses just puts people at increased risk. Skip this, but the treatment for glucocorticoid for adrenal insufficiency, either primary or central, is going to be the same for cortisol at least, which is glucocorticoid replacement. And hydrocort is our preferred agent because it matches physiologic glucocorticoid replacement better than things like prednisone, prednisolone, or dex. And your typical dosing is going to be 15 to 30 milligrams daily divided in 2 to 3 doses. The other way that you can calculate this is 10 to 12 milligrams per meter squared of someone's body surface area. And the way that this is typically dosed is a dose in the early morning when you expect people's cortisol to naturally peak, a dose in the early afternoon around 2 p.m. And the way that those doses are split is your higher dose is going to be in the morning in a kind of 2/3 to 1/3 regimen. So oftentimes a regimen could look like hydrocortisone 15 milligrams in the morning upon waking, and then 10 milligrams in the early afternoon around 2 p.m. As a starting point, at least. And if people have, evening tiredness and, or evening lethargy, fatigue, nausea, those symptoms that we talked about, adrenal insufficiency, that's when you might also add a third dose or, adjust your total dose and split it a little bit more evenly over the 3 doses. The symptoms of for monitoring for this, the symptoms of over replacement that we look for are weight gain, insomnia, skin infections, hyperglycemia, Cushing's features. So that's things like, overall Cushingnoid appearance, truncal obesity, abdominal striae. It's going to be, the buffalo hump, which is dorsocervical fat pad, and then supraclavicular fat pad as well. There's sort of a limited role for lab monitoring. We don't often retest people's AM cortisols, their ACTH or cosentropin test. It's really based on what symptoms and exam findings they're having. And then symptoms of under replacement are going back to those initial symptoms of adrenal insufficiency. So nausea, poor appetite, weight loss, and fatigue. Joey, your question is treatment expected to be long-term and supportive, or is there a possibility of recovery of intrinsic function? So I think that depends a little bit on what the underlying etiology is going to be. Oftentimes, if, in central AI, if people have if their ACTH is suppressed because of steroid use, then I would expect that to recover over time if they're able to come off their steroids, or if they have something like a pituitary mass or pituitary macroadenoma, then in about 50% of patients, their function can come back over time. And then I think it's a little bit hard to say with the etiologies of primary AI with autoimmune adrenalitis. That I'm not sure about what the typical recovery is. But then again, if you have things like, lymphoma or metastatic involvement or TB related primary adrenal insufficiency, I think it just depends on what your course of recovery and treatment looks like from those underlying etiologies.
Makes sense. Thank you.
Mhm. Okay, so basically everybody with both primary and central AI is going to get cortisol replacement. Only patients with primary AI are going to need aldosterone replacement or mineralocorticoid replacement, and that comes in the form of fludrocortisone. And our typical dose is either a low dose of 0.05 to zero point 0.2. And oftentimes we'll replete someone's glucocorticoids first and then see what their mineralocorticoid needs are. Because especially if we're using hydrocortisone, we'll start with a little bit of a lower dose. So that fludrocortisone 0.05 dosing, because hydrocortisone has some inherent mineralocorticoid activity. And so we'll see, how their symptoms are after starting hydrocortisone, and then measure their labs, including their sodium and potassium, and see if those normalize. And then part of this monitoring is also going to be plasma renin and aldo, and you're wanting to see those normalize as well. Again, in primary AI, you're going to see high renin, low aldosterone. And so if those are starting to normalize, then you may be at a good fludrocortisone dosing. It's a little bit different if people are on other steroids like prednisolone, or prednisone, or dexamethasone. Prednisolone and prednisone have a little bit of mineralocorticoid activity, but dexamethasone basically has none. So those patients, you would typically start at higher dosing, 0.1 rather than the 0.05 with hydrocort. And so this is, you're going to monitor people's electrolytes in their labs, renin, aldo, but then you're also going to look for signs of excess replacement. So if you have excess aldosterone, you're going to have things like edema, hypertension because of holding onto too much salt and water, and then hypoklemia because you're kicking out too much potassium. And then inadequate replacement, sort of the opposite, right? Hypotension, we're retaining too much salt and water and potassium. So regular monitoring for those basic things is going to guide your fludrocortisone dosing. And then the last hormone that we think about replacing, and this again is back to DHEA or androgens are going to be low in both primary and central AI. The data for replacement is not as robust. We don't have really clear evidence of like serious adverse effects for replacing these, but there's also no good long-term safety data for replacement of this androgen DHEA. And we really only think about DHEA therapy in females because the predominant androgens in males are produced in the testes. So relative androgen depletion because of the adrenal glands doesn't have really that much of an effect in males. And the symptoms that you are looking for in thinking about whether someone warrants DHEA therapy are going to be signs of androgen deficiency. So you can think about low mood, low libido, energy. And this again, like our talk about mineralocorticoids, oftentimes we'll try it out. Make sure we optimize someone's hydrocortisone regimen first before we think about if someone needs DHEA therapy. And it can be hard because there can be a lot of overlap. And then especially if someone has central adrenal insufficiency with, FSH and LH and all those other hormones, those can also confound the picture. But a reasonable sort of, if you feel like other hormones are in a good spot, including their glucocorticoids, then a reasonable place to start is 25 to 50 milligrams daily for 3 to 6 months. And you're going to monitor people's androgen levels and then look for improvement in mood, energy, libido. And then adverse effects are acne, hirsutism, increased sweat and odor. And because we don't have a lot of data around the benefits of this. This is really a place for individualized counseling and frequent check-ins to see if people feel like they're really benefiting from this therapy or not. All right, so what we've been talking about has been about chronic adrenal insufficiency and thinking about how to evaluate and monitor that in the outpatient setting. I think, like I mentioned at the start, the experiences that I've had really thinking about adrenal insufficiency have been more in a very acute kind of setting where people present with hypotension, we're worried about sepsis. They're on, we've fluid resuscitated people, they're on a couple pressors, and then we think maybe they also need additional steroids to maintain their blood pressures. So it's not really a agreed upon definition for this, but it's basically an acute deterioration in someone's health with hypotension that's thought to be due to cortisol deficiency. And some of the definitions mention rapid improvement once you start stress dose steroids. I think this can be hard because oftentimes adrenal crisis is precipitated by a pretty serious infection as well. So you can have this like concomitant sepsis and adrenal crisis picture. And so if someone doesn't, respond immediately to steroids, doesn't mean that they don't have adrenal crisis. It means that they're really sick and maybe have something going on outside of their adrenals being impacted. So every year, about 6 to 8 patients with adrenal insufficiency have an incident of adrenal crisis, and it's similar between primary and secondary AI. It's really morbid, and 40% of chronic AI patients have had at least one adrenal crisis in their lifetime, with 20% having experienced more than one episode. So the way that I think about this is adrenal crisis or acute loss of your cortisol production can sort of manifest in a couple of different ways. It can be someone's first presentation from an acute episode of adrenal insufficiency due to those etiologies that we talked about. So that can be either like someone has a pituitary infarct that's really acute, Sheehan syndrome, which is that postpartum hemorrhage and pituitary infarct, which can cause immediate loss of cortisol producing ability. Or it can more commonly be the way that people with chronic sort of indolent AI present because they're not able to mount a stress response to an acute precipitant. And the most common precipitants of adrenal crisis in that population are infections, especially gastroenteritis. If someone's been on steroids and then they have gastroenteritis and aren't able to take their PO hydrocortisone, and that can exacerbate a crisis, abrupt discontinuation of glucocorticoids, and then really any significant stressor, whether that's a procedure like a dental surgical procedure, an MI, allergic reaction, significant psychological stress. And your evaluation here is going to be, evaluation isn't actually as important here, but if you are going to evaluate, you can get a random cortisol. If it's less than the threshold of 18, then that's suggestive of AI. And the reason is that for this higher threshold is that in these really stressful times, you should be able to mount a significant cortisol response. So if it's low, then that's going to be indicative of AI. And for the management of this, the key is really to start steroids. If you're suspecting it's going to be a hydrocortisone stress dose. And if you're able to get a random cortisol and an ACTH prior to starting, then that can help down the line when you're doing things like cosentropin stim tests. And that can be helpful in the outpatient setting for determining if someone actually had adrenal crisis at the same time that they had everything going on. But these patients are going to be really hypotensive. They may be hypoglycemic. So you're going to be volume resuscitating people. There's not a lot of guidance on what adequate volume resuscitation really looks like, but that's a clinical judgment. We don't have things like 30 cc's per kg guidance like we do in sepsis, but these patients typically need like 2 to 3 liters of fluids in the first 24 hours, and then maintenance D5 if they're hypoglycemic. And then typical stress dose regimen is going to be 100 milligrams bolus and then followed by 50 milligrams Q6 after that. So that's about 200 milligrams per day while people are acutely sick. And that's about 8.5 times what your physiologic regimen is going to be. Hydrocort is preferred because it's, again, short acting, you can titrate it, but also because hydrocort has that mineralocorticoid activity. Above doses of 40 milligrams of hydrocort per day, you're basically saturating your mineralocorticoid receptors. But if you don't have hydrocort available, then you can use Dex or methylpred. But in those cases, you do have to start fludrocortisone as well. So just remember, hydrocort, it's going to act on both your glucocorticoids and your mineralocorticoids, but Dex and methylpred will not. And then if people are getting better quickly, you can taper their steroids to their home regimen, which again is between 15 to 25 or 15 to 30 within 3 days if they're improving. All right. And just to wrap up here, these patients are going to have an endocrinologist who are going to go over these things with them, but these patients are also at risk for adrenal crisis, which can be really morbid. So anytime they have encounters with the healthcare system, it can be helpful to just review some basic education around contingency planning and what to do if people get sick. So all these patients should have a medical alert bracelet and what's a steroid card, which is shown on the screen, that they carry with them, that informs, emergency medical providers that these people have adrenal insufficiency and need high doses of hydrocortisone or glucocorticoids if they're going to be sick. Symptoms of acute cortisol deficiency, which we've talked about, and then anytime these patients get sick, they should double their or triple their dose. There's a little bit of different counseling that you can give people on this, but if people have like a viral URI, then you can ask people to double their dose for 3 days while they're sick. And then if people have febrile illnesses, then they can double or triple their dose based on how long that's going on and based on how severe their symptoms are. And then all these patients should also carry a vial of hydrocortisone in case that they have things like gastroenteritis, in case they have things like altered mental status, and ideally they have family who feel comfortable with, drawing up their hydrocortisone and giving IM or sub-Q injections as needed. And then for high physical activity or high physical stressors, things like running a marathon, that's also a time to increase people's doses of hydrocortisone to like 2.5 to 5 milligrams before your stressor, and then every 2 to 4 hours after that as well. And then finally, this is a website, the National Adrenal Diseases Foundation. They have a lot of what I just talked about in terms of contingency planning and guidance for patients and patient education resources on their website. And this can be a really good resource for people to go look and see what they should be doing for minor surgeries and when they're ill and how to adjust their steroid regimens. All right, here are my references. And then I'm happy to answer any questions if we have time.
I think we'll head to the break, and if folks want to ask questions while we're breaking, we'll do that. But let's plan to be back at 10:53 for Andrew's chat.